The next one is farmer's lung. This is the last of pneumoconiosis we are going to see. It is caused because of the inhalation of moldy grey or grain dust. Again, not difficult to remember because farmers basically deal with hay or grain dust. There is growth of thermophilic actinomyces, that is Micropolyspora pheni. So again you have a etiology here which is infective. Micropolyspora pheni is the actinomyces which is responsible for farmer's lung, the main cause of farmer's lung. Characteristics are by general and respiratory symptoms and physical signs. So there is really nothing which is special about this. It looks like all the other pneumoconiosis. No special segregating factors available here. Repeated attacks cause pulmonary fibrosis and inevitably cause pulmonary damage and cor pulmonale. Now what we know is that these conditions are pretty common in India, but we do not know the exact prevalence of farmer's lung. But going by the way we have things here, we know that farmer's lung would be pretty common because there is a lot of farming population in India. So therefore, by that simple logic, we estimate that farmer's lung should be a very important disease. Coming to the next small topic, and that topic is lead poisoning. Lead poisoning is another important topic. Out of all the poisonings, lead poisoning is the most frequently asked poisoning. What are the sources of lead poisoning? You have industrial uses of lead, which are for batteries. You know there are lead batteries, glass, shipbuilding, printing and pottery. Non-occupational sources are gasoline and leaded petrol, lead pipes, lead paint and toys are some other miscellaneous sources. Out of these, petrol was a very important source of lead. If you remember, nowadays we get unleaded petrol. The petrol that we have is unleaded petrol. Earlier, we had leaded petrol. The fumes of those leaded petrol had a lot of lead which was directly inhaled into the respiratory system and caused a lot of problems. Now, fortunately, as leaded petrol is phased out, that problem has been taken care of. The next is lead pipes. These days we don't afford lead pipes. Gone are the days when we used to have lead pipes. Lead paints and toys are a different story. Many cheap toys make use of lead-based colorants, and lead paints is still available for some of the paints. So nowadays you have these advertisements of paints that we do not have lead, we do not have VOC, there is no gadbad and all those advertisements. So that are basically talking about absence of lead in them and absence of other problematic substances like VOCs. We were especially concerned about toys because lead, like iodine, hits hardest when the CNS is maturing, and that is in children. So if the child is exposed to lead paints, the child has the maximum effect of it. Therefore, toys should be very carefully chosen and should be preferably of good make. Mode of absorption for lead. You have inhalation, and I have written in the bracket that it is the commonest mode in industry. Again, can be asked, is asked and will be asked. What is the commonest mode of lead? It is inhalation. So by the way of inhalation, we have the most lead burden. It is paradoxical because you know lead is a very heavy metal and therefore it is likely to be asked. Lead being a metal, heavy, still the mode of ingestion or the mode of action, it enters the body through inhalation. Second is ingestion. Ingestion is when you take it, when you eat it, when it goes into your GIT, it is absorbed, that is ingestion. And the third is direct contact with skin and it gets absorbed into your blood, that is tetraethyl lead or organic lead. Tetraethyl lead is a form of organic lead. Remember, there are basically two types of leads, organic and inorganic. Organic can get absorbed through the skin. So therefore, tetraethyl lead being organic lead is also absorbed through the skin. A recommendation here, ask the workers to wash their hands before they have their food. Also, please ask them not to bring their food to the workplace. Both of these would reduce the lead burden if they are dealing with tetraethyl lead or any other form of organic lead. What are the clinical features of lead poisoning? As you can see, they are divided into poisoning by inorganic lead and poisoning by organic lead. If you have poisoning from inorganic lead, you have those classical symptoms which you are aware of. You have abdominal colic which does not resolve. You have obstinate constipation, again does not resolve. Took laxatives, high fibrous diet, but constipation is not resolving. There is loss of appetite. There is a blue line on gums. Blue line of gums, is so pathognomonic again that they have stopped asking this. But still you should know, because if you miss this, it would be a huge embarrassment. If you have that greenish bluish line on your gums, then it is a sign of lead poisoning. What happens is that lead is excreted in saliva, and this saliva is then utilized by the bacteria that are on the gingival lining. They die and you get the deposition of this bluish green line on the gingiva because of lead poisoning. You also have neurotoxic effects of lead, and they manifest as wrist drops. Plus you have anemia and you have basophilic stippling. I hope you know what basophilic stippling is. You have those small fine blue dots inside of an RBC, and they are pretty sensitive indicator for lead poisoning. So I told you, mesothelioma, you have your ears must be raised for asbestos. This you have basophilic stippling, you must surely suspect of a lead poisoning. It is a very sensitive indicator for lead poisoning. Plus you have depression of the hematopoietic system and therefore resulting anemia. Coming to the effects of organic lead. Organic lead is basically the form of lead which acts on the CNS. So the symptoms of organic lead or tetraethyl lead, as we saw, which was absorbed through skin, are primarily on the CNS. So you have insomnia, headache, mental confusion and delirium. Again, non-specific symptoms. Occupational history would be very important. Contact with lead would only lead you that this is probably the effects of organic lead, because they are very much unspecific. Insomnia, headache, mental confusion and delirium are all CNS symptoms, but they can happen in a lot of other things also. Coming to the diagnosis of lead. First of all, as I said, history would be very important. Secondly, clinical features. The clinical features would show loss of appetite, intestinal colic, persistent headache, you have weakness, abdominal cramps and constipation, joint and muscular pains, blue line on gums and anemia. So the list that we just saw, that is found in clinical examination. Lab tests, these are important. The values are also asked. So what you need to know is what test we do, plus you also need to know what values are there. The first test that you have on the list is coproporphyrin in urine more than 150 micrograms per liter. So more than 150 micrograms per liter coproporphyrin in urine, lead poisoning. Aminolevulinic acid in urine more than 5 milligrams per liter, ALA, in short it is called as ALA, more than 5 milligrams per liter. Lead in blood, direct assessment of lead in blood. So no left, no right, let us have lead in blood. A level of more than 70 microgram per liter shows that there is an exposure to lead. You also have a urine level which is more than 0.8 milligrams per liter. Remember, this 70 is a microgram and this 0.8 is a milligram. So you have blood levels as well as urine levels for lead. Out of these two, the blood levels are really important. Most frequently asked are the blood levels. So what you need to know is, okay, 70 micrograms per liter. This is the level of lead above which, if you have it in your blood, you have been exposed to lead or you are suffering from lead poisoning. Basophilic stipplings of RBC, as I told, is a very sensitive indicator for hematological response to lead. What are the other? You have coproporphyrin, like we discussed, and you have ALA. But the direct level of lead, probably the most important and most frequently asked. What are the preventive measures for lead poisoning? First and foremost, again, substitution. You don't need lead these days in many industries. So if you don't need lead, let it go. Have a safer alternative. Say for example, we just discussed petrol. There is no need of adding lead to the petrol, and it is not added, by the way, but you can remove it. So we removed it. There is no need of adding lead into paints. So therefore, we substituted lead by other safer alternatives. So that is substitution. Isolation is anywhere lead is liberated, you have risk of inhalation. That process should be done in an enclosed chamber so that people don't go into that chamber and inhale a lot of lead. Local exhaust ventilation. Lead is generated, okay, I throw it out by ventilation. Personal protection, again, respirators, filters, these are personal protective measures. You can wear gloves. You can also have protective gels that you apply on your hands. Hand washing before eating and not bringing food into the factory are other measures. Good housekeeping. Very important. I want the area to be clean. I want my tables, I want my desks and benches to be wet mopped. What is wet mopping? All those fantastic TV ads you see, those mops and you have the floor cleaned. So the floor must be cleaned by wet mopping. Dry mopping does not remove lead. I want a wet mopping for all the places where lead exposure is possible. Working atmosphere should contain less than 2 milligrams per 10 cubic meter. Another number you want to, the working atmosphere should contain less than 2 milligrams per 10 cubic meter of lead, and that is a very strict level to ask. Okay, that should be adhered, otherwise inhalation of lead would occur. Periodic examination of workers, laboratory determination of urinary lead, blood lead, red blood cell count, hemoglobin estimation and copper porphyrin test of the urine can be done. So basically these tests are repeated periodically for assessment of lead exposure in the factory. Personal hygiene measures, which I just discussed, and of course health education. People should be made aware that this is an hazardous industry, lead is used, and what you should know about it and how to prevent it. Management. The objectives of management of lead poisoning are, the first and foremost is prevention of further absorption. So we need to stop further absorption. From that, the removal of soft tissues, and for prevention of recurrence, we give a saline purge. A saline purge is given to remove unabsorbed lead from the gut. So at least what is gone inside, that should not be absorbed, and therefore we use a saline purge. The chelating agents that we have are D-penicillamine and calcium EDTA. I am sure you would have heard about it. The same agents, D-penicillamine and calcium EDTA, are used for chelation of lead so that they stop further absorption of lead, because lead, once it is absorbed and it is into the circulation, it basically finds its place in the bones. So when osteoblasts lay bones, they catch lead and they put lead into the bones. When there is resorption of bones for a very long time, you can imagine that the lead can slowly leach out from the bones and can have a toxic effect on the body. So it is a very dangerous metal to have, because it goes and stays in the bones, and when resorption occurs, it comes back into the bloodstream and can have its toxic effects continuously. So therefore, lead, calcium EDTA and D-penicillamine are used so as the lead is chelated and it is not available to be laid in the bones. They are chelating agents and work by promoting lead excretion in the urine. Lead poisoning is again a notifiable disease and of course is a compensatable disease according to India. With that, we finish off with lead and we go on to the next topic, and that is of occupational cancers. First and foremost, one cancer you want to know in occupational cancers is skin cancer. The most common occupational cancer is skin cancer. So, if you want to know about one cancer, this is the one. And as I already told, Percival Pott first drew the attention to cancer of scrotum in those lads who swept chimneys, and he saw that they were rubbing their scrotums against the chimneys apparently, and they got scrotal cancers. And therefore, that started, as I told you, the momentum towards occupational health. 75% of occupational cancers are skin cancers, and I have boldened that, not because it is an error, because it is very important. Skin cancers are an overwhelming majority of cancers associated with occupation, and I should know. Skin cancers are an occupational hazard among gas workers, coal oven workers, tar distillers, oil refinery, dye stuff making, road makers, and in industries associated with mineral oil, pitch, tar. Broadly, I get an idea, anything that is black causes skin cancer. Okay, tar, pitch, mineral oil, everything is black. So black liquid, okay, skin cancer. Remember it that way. You have exposure to black liquids, coal, tar, pitch, something to do of that sort, solvents, this is all skin cancer. The next we have on the list is lung cancer. How can it be far behind? Lung cancer is a hazard in the gas industry, asbestos industry, nickel and chromium work. Basically, what I hear is all heavy metals, okay, all metals which are heavy, fancy names. Arsenic roasting plants, and in the mining of radioactive substances. So this is lung cancer. We already know that uranium mining, we had taken that example also of Kerala and of uranium mining in epidemiology. So we know by that knowledge uranium mining is a positive risk factor for lung cancer. Any heavy metal inhalation industry, lung cancer. Arsenic, beryllium and isopropyl oil are suspected carcinogens, but they are not proven. More than 9/10 of the lung cancer are attributed to tobacco smoking, air pollution and occupational exposure. I say 9/10, that is almost 90%. Okay, 9/10 is 90%. So 90% of cancers are thus avoidable. You have 90% of the cancer burden is avoidable, is a big deal. Okay, so if you control smoking, air pollution and occupational exposure, 90% of your burden of lung cancer is taken care of. Coming to the next cancer, bladder cancer. This is a fancy one. Bladder cancer is really a fancy one because bladder is an inside organ. Skin I understand, lungs I understand, bladder. Bladder is an inside organ. I don't smoke and I don't see how bladder cancer is affected. So let us see how bladder gets involved. Cancer bladder is seen in aniline industry and rubber industry. It is caused by aromatic amines which are metabolized in the body and excreted in the urine. And where is the urine stored? The urine is stored in the bladder. These are carcinogens. Those carcinogens get enough time with the bladder. They mutate the transitional epithelium into the bladder and voila, you have a bladder cancer. So this is fascinating. Bladder is inside, but because urine is stored and urine has those carcinogens, you get bladder cancer. Again, you want to remember the industries, aniline and rubber industry. Pretty easy to remember because they are really different. Aniline and rubber. We were also seeing what are the specific constituents which cause cancer. The industries associated with cancer bladder are dye stuff making, dyeing industry, rubber, gas, electric cable industry. So basically what I read is rubber and dyes. Rubber and dyes. Anything to do with this, I get bladder cancer. Anything to do with dyes and rubber, bladder cancer. So bladder carcinogens, the specific list are beta-naphthalamines. I get a clue, a bulb goes off. Naphthalene, oh, that sounds like those pills that I put for moth in my wardrobe. Okay, beta-naphthalamine, bladder cancer. Benzidine, para-amino diphenyl, you can also have bladder cancer by auramine and magenta, which are used as pigments. So that was bladder cancer. Moving on, passing remark on leukemia. Benzol, X-rays and radioactive substances can give rise to leukemia. Leukemia may appear long after the exposure has ceased. And how long? Really long, decades. So leukemia may appear decades after the exposure has stopped. That was about leukemia. Coming to the general features of occupational cancer. So as a family, what are the features for occupational cancers? The first thing are that they appear after prolonged exposure. A long exposure is needed for occupational cancers to appear. The period between exposure and development of the disease may be in decades. The disease may develop even after the cessation of exposure. We saw, in cases of progressive massive fibrosis, this can happen even after the exposure has stopped. The average age incidence is earlier than the cancer in general population. Say for example, a cancer is common at the age of 40 in general population. In occupational cancers, the age is comes before, say for example 30. So if it is common in 40, now in occupational cancers it will come at 30. So the disease is preponed, so to say. The localization of the tumors is remarkably constant. Scrotal cancers, who gets scrotal cancers in childhood? And those all of them are chimney sweepers. So you get an idea, this is localized cancer and the localization is remarkable. Personal hygiene is very important in prevention of occupational cancers. Cannot be emphasized enough. Hand washing, bathing, washing your clothes, changing clothes, not bringing food to the office, wet mopping of the surface are all practical suggestions, and in the long term would prevent a lot of occupational cancers. Control of occupational cancers, what we can do about it? Elimination or control of industrial carcinogens. We saw a lot of examples already. Exclusion of carcinogens completely from the industry. You can have well-designed buildings or machinery, local exhaust ventilation so that the carcinogen does not accumulate. You also can have closed system of production. The carcinogens are out, I am here, so I don't have the contact with those carcinogens. Periodic medical examinations, inspection of factories for fitment, proper operations and proper maintenance, notification of disease, licensing of establishments, personal hygiene measures, educations of the workers and management, and continuing research. So these are the various strategies you can apply for control of. With that, we conclude this lecture. I'll see you in the next class.